Good morning. It's great to be here. It is great to see a large, interested audience. I know that our audience really spans disciplines. Some of you are school counselors, clinical social workers. We have psychiatrists. We have family members. I think we have correctional staff, a wide range of people. So people will have interesting questions. My task is to give an overview of borderline personality disorder, what we know about what it is, how to understand it, what the expected course and outcome is, something about its genetics and neurobiology, and in as accessible a way as I possibly can, I will try to do that. So I don't have any relevant financial disclosures. Let's start by talking about the diagnosis. And within the personality disorders, this is one of the 10 established personality disorders, and it has criteria that I've grouped here in 4 areas. The first is an interpersonal hypersensitivity. People with borderline are more sensitive to their interpersonal context. Do they feel cared for? Do they feel understood? Is there somebody they can find that will make them feel that way? That becomes very important in understanding the disorder. Then there becomes a fear that somebody could leave or abandon, leading to instability of relationships. I'm going to get into that a little bit more. In reaction to the interpersonal context, we see a number of symptoms: affective or emotional dysregulation, what we call instability of affect, people's mood changes over a period of hours, inappropriate or intense anger. This tends to be what people think of as borderline, although it's not necessarily the most common or salient of the criteria. Emptiness. Behavioral problems are the next group of problems, and we group these in 2 different areas. One is self-injury and suicide attempts. The other is impulsivity in other areas, reckless driving, threats, binging, sex. And finally, an internal experience of a disturbed sense of self, an unstable or distorted self-image, depersonalization or derealization, paranoia under stress. So if you can remember these 4 areas, interpersonal, emotional, behavioral, and self, you can start in your mind to understand where the criteria fall of someone with this disorder. This slide is Dr. John Gunderson's work, and it's grouping the criteria by context. So that at the top of the slide, what you see is that when patients who are emotionally sensitive feel held, understood, there's a new significant other in their life, a new professional in their life, they can be idealizing, a little bit dependent, sensitive to rejection. But inevitably, this is threatened. There is no relationship that is universally supportive. So with that perceived interpersonal stress is when the symptoms really emerge. So when that is threatened, patients can be devaluative, self-injurious, angry, anxious, help-seeking. Now that elicits one of 2 responses in the environment. Either, on the right side of the slide, the other person says, "Whoa, not for me," and pulls away, or the other person gets much more close, understanding, helpful. If the other person gets much more close, understanding, helpful, then we return to that top phase, held. All right, things are okay. If the other person pulls away, this fear of abandonment is actually becoming true, and the patient feels alone, dissociated, paranoid, impulsive, help rejecting. Now again, that may elicit even more behavioral symptoms or internal symptoms, suicide attempts, and could again elicit greater holding, hospital, jail, somebody else, or lead us to that bottom part of the slide where people really do conclude that they aren't lovable, that ultimately there's nothing or no one that can help them escape this despair, and that the clinical pearl here is that borderline patients really are at risk of killing themselves when they conclude that they aren't lovable. So if you can understand the context in which symptoms emerge, you're already far down the road of differentiating borderline from other disorders. There's a lot talked about with this bipolar overlap. And it's not simple, because about 20% of patients actually do have both. There probably is some brain circuitry that is common to the two disorders. And it's also not simple because in comparison to unipolar depression, bipolar depression, meaning you've got mania and depression, that depression tends to start younger, tends to have more abrupt mood changes, more slowed down type depression symptoms, and more comorbidity, especially substance use. So darn, I just made it harder. Like you were just starting to get it. You got the context, you got those 4 areas, and now I just said, well, they could be bipolar. Oh, crap. All right, let's make it easier. So bipolar is a condition where people have sustained mood symptoms over periods of days to weeks. They have elations that last 4, 7, or more days, depressions that last 2 or more weeks. So they're much longer lasting, and they have these periods where they're up. Borderline, much less so. These are changes that happen over hours. More anger, more anxiety, more mood reactivity, more irritability, aggressiveness, and impulsivity. So this is a different phenomenon that is often clinically cared for very poorly. Upwards of 40% of patients with borderline have been inaccurately told you have bipolar. You guys have seen it, right? I mean, this is not uncommon. I have no good explanation for this. Bipolar is a serious mental illness that is generally lifelong, needs to be managed. As I'm going to show you, borderline actually has a much better outcome. I think clinicians get a little bit afraid of making a diagnosis, talking about something that they may not have ample treatment for, and want to find something else. It's not good practice. Key here is to think interpersonally for borderline. Abandonment, intolerance, and self-injury in reaction to the context are key. Those 2 pieces, intolerance of aloneness and self-injury in reaction to the interpersonal context, are key distinguishing features for borderline. Irritability and anger with activation of the attachment system rather than with strangers. I always point out that borderline symptoms don't tend to occur on islands. On islands. They just don't. Bipolar symptoms may. You can get a manic patient on an island and they'll still be manic. Borderline patients, less so. So when you're trying to assess, you're trying to get a history that looks at the relational life of the person. Is this triggered by interpersonal stress, breakups, et cetera? Is the depression treatment resistant? As I'll show you, the depression does not tend to respond very well to typical treatments. Does the patient self-harm, and what's the function of the self-harm? And are the relationships unstable? So if you can get those 4 questions as you're trying to assess, you really are pretty far down the road of understanding and differentiating in your own mind what we may be talking about here. Okay. That's a pretty broad brush overview, but it's actually most of the key things. So if you got that, you're good on the diagnosis section. All right. Now, for adults, this gets slightly more complicated because adolescence, and certainly my adolescence, is and was a period of some internal instability. I don't know if you all remember your own, and those of you who work with adolescents, you see this. So what do we focus on that distinguishes what's disorder from what's normal adolescence? And I think there are 3 things that you really want to key in on that are more adolescent specific. Dr. Aguirre is an expert at this, and we'll talk about this in more detail, I'm sure. But self-injury and impulsivity are important. The quality of the relationships is important, and the nature of the depression is important. For adolescents with borderline, it's not as useful to focus on this identity disturbance and the reactions to an unclear identity. It just doesn't help you very much. So you're really going to key in on the nature of very reckless impulsivity in response to things and the quality of the relationships, especially intolerance of aloneness and abandonment sensitivity. If you can get those two features, you're really in the ballpark for a lot of this. Okay. All right. Next section, you up for another one? I've got 5 of these. You've made it through the first one. Yes, somebody started to clap. Yes, we did it. All right. Epidemiology, genetics, course, and outcome. Oh, those are big words. Basic facts. So this is seen in about 2 to 3% of the population. The unfortunate part is actually my slide may be wrong. The biggest study was 40,000 door-to-door surveys looking nationally at a representative sample, and in that, 5.9% of the population met criteria for borderline. So some people are using the 5.9% number. I think that may be accurate. It comes from good data, well-researched population data. In clinical samples, it's certainly much higher, 15 to 20%. The gender thing is interesting. So we see that in clinical samples, it tends to be more women than men, more girls than boys. 75% or so, higher in some centers. In community samples, this 40,000 door-to-door survey thing I was talking about, 50-50. So that women are overrepresented in treatment samples. The thinking on this is, and you can have your own thoughts, those of you who work in corrections, I actually would be interested in talking with you about your experience of this. A lot of people would say that men are more likely culturally to end up in substance use disorder treatment or correctional facilities for the same behaviors that women may engage in. No one knows. I don't think this is yet worked out. But it's interesting, and I think we minimize male borderline at our peril. It's one of those, I think some of this, we were talking we had a fascinating, the Mulligans were so incredibly kind to host a reception last night. We were talking about the stigma of this disorder. It's a heavily stigmatized disorder, as we all know. Why? One of the aspects may be the sexism of women behaving badly and being labeled. And I do think we can do some good from a stigma perspective at also recognizing the context in which this all emerges. It's an aside. So, turns out this is a pretty darn genetic disorder. It ranks up there just below schizophrenia and bipolar, in terms, but ahead of depression, ahead of PTSD, ahead of anxiety disorders, ahead of OCD. In 2 big twin studies and 1 family study in the last 5 years, the question was, do those 4 parts that I was telling you about, the relationship part, the impulsivity, behavioral part, does the emotional part and the self part, maybe you could inherit like 2 of the 4 and that would make you more likely to have borderline and those sort of traits run in your family? Not so much. It turns out that looking across the twin studies and the family studies, it's really best understood that the disorder itself, first of all, it holds together very well as a disorder. Second, it's very heritable as a complete package. So the genetics of this tend to support understanding borderline as a unitary construct. Now, what happens post-diagnosis? This was a shock to the field when it began to be published. These data have been out there, but they're still not very widely disseminated, and this may be new to some of you. On this slide, it's a complicated slide. I stole it from Dr. Gunderson. He told me I could. He's not, I hope he doesn't, it's videotaped, what if he sees? Oh my God. But if you look at the orange bar, this is from a study, multi-center study, that looked at borderline personality disorder across several major centers. This was actually pretty socioeconomically representative, and it was just a natural study that says what happened. And at time 0, the average person who entered the study met 6.7 of those 9 criteria. Okay, so you need 5 officially for the diagnosis. They met 6.7, all right. They followed these folks, and by the end of year 1, the average person in that study met 4.2. By the end of year 2, 3.8, on down. So that by the end of year 10, the average person in that study only met 1.7. Huh. Same thing in another big study. This one I've plotted in the blue line. This is the McLean study of adult development, started with 362 inpatients hospitalized at McLean Hospital in Belmont, Massachusetts. And they followed those out. Mary Zanarini was the principal investigator on that. They've got 90% of the patients followed. It's amazing how she's kept her sample together. But interesting that at year 2, 35% had remitted. At year 4, 50% had remitted. So that by the end of 10 years, 82% no longer met criteria for the, oh, it wants me to join cable Wi-Fi. Okay, back to the lecture. So by the end of 10 years, 82% no longer met criteria, which was, again, surprising, but it fits that you see this disorder less in older folks, either from social learning, treatment, or the natural evolution of the brain. I'm not sure we're sure yet. We see this change. What's interesting in both of these studies is that once remission is achieved, relapse was fairly rare. This is good news. So when I said this is a better prognosis than many of our illnesses, certainly bipolar, even regular old depression tends to recur. With borderline, if it can be accurately identified, you can see substantial improvement. Now, to the topic of the day. Identifying this disorder early, intervening early, is critically important. In all of these studies, people who are older don't get as better as fast or as much. Younger people who are identified and treated tend to have better outcomes. Now, that said, this is still obviously a very serious illness with massive impacts on people's life. You get young people, they're off their trajectory, so that after 10 years of follow-up, only about a third had full-time employment, only about a third had a stable marriage or partnership. I say to my patients, we want you in that third. The goal is you're the one that 10 years from now, you're in a stable marriage, you're working full-time, this is the goal. And that's what we should expect. But the expectable course is one of improvement, and the expectable course may be that it's difficult to get full vocational and social integration or development. But I think that should guide our treatment. I think we as healthcare providers and mental health providers need to be thinking, what are we doing to help the patient function well as a part of our treatment? It really supports a rehabilitation model and integration. People are anxious, avoidant, want to pull away from exposing themselves to the difficulties of work, relationships. It becomes really important to support patients in doing that based on this data. The other thing is that borderline had a markedly negative effect on major depression, so much so that the depression tends to be treatment resistant. So you can try SSRIs, you can try whatever meds you want, you can do ECT. It tends not to work so well with borderline until the person no longer meets criteria for borderline. When the borderline remits, then the depression gets a whole lot more treatable. So there is a myth that you should treat depression first and then see if they still look borderline. That's nonsense. If a patient has borderline and depression, borderline really should be the primary diagnosis that you focus on and helping the patient manage their interpersonal sensitivity, their reactivity, how they're going to manage their emotional reactivity and dysregulation. These things matter. If you want, I'll give you this. This is the advanced slide. You don't have to, you can tune out for a second if you don't want it. This is what happens with bipolar. Bipolar, there's no impact of bipolar on borderline, and there's a very mild impact of borderline on bipolar. That's the summary. So that's enough. So otherwise, we'll get in the details. Clinically, the good news is most patients with borderline achieve remission. That's what I just showed you. Relapse tends to be rare. Work and social impairment tends to persist even after the symptoms get better. Should guide your treatment. Work and social impairment tend to persist even after symptoms get better. Should guide your treatment. Impulsive symptoms tend to be the first thing to get better. People's behavior improves most quickly, typically. And borderline negatively affects the course of major depression, renders it treatment resistant, persistent. All right, you made it through section 2. You doing okay? This section's kind of fun because I get to show you brain slides or brain images, but it's biological. It's kind of interesting, though. So this requires that I teach you what I understand of emotion regulation in the brain. And I'll do that by telling you a story. If you're walking down a path and you see a snake coiled up, rattling, and you're afraid of snakes like I am, I really am. Telling this story makes me anxious. Just to be honest. You instantly have a fear response. And then something interesting happens. Your brain kicks in and says, okay, we're in a zoo, the snake is behind glass, there are other people around, I think I'm gonna be okay. Oh my God, I think I'm gonna be okay. So what you have here is the amygdala, the fear-based center of the brain, getting that initial emotional response. It goes through the insular cortex, and then the prefrontal cortex, the planning, sequencing part of our brain, helps regulate that. Think about what we're gonna do, how we're gonna manage it, gets things back in check, and feeds back, okay? So you got the basic idea that brain gets stimulated, the thinking part of the brain kicks in and helps you manage that fear. Now, you got two parts to this. If the first part doesn't go so hot, meaning if you feel that fear much more intensely than the average person, it's gonna be harder to regulate. Or if the second part doesn't go so hot, it's hard to think straight in the face of your emotions, it doesn't go so hot either. You stay intensely afraid and get overwhelmed, and it's hard to come back to baseline. And there's emerging data in borderline that there are problems in the brain with both of those parts. So there's an increased amygdala response and a decreased cortical regulation of the response. Does that make sense? Got the concept? Since this is being videotaped, I will just say, there are some conflicting studies on both ends of that spectrum. I'm giving you what I think is the preponderance of the evidence, but I am simplifying it slightly. If any of you are neuroscientists, we can talk on the break and we can do the more advanced version. All right, so my favorite study of this was an old study done in 2003, and they showed this woman. She's got 4 faces. She's famous for doing this. It was kind of her. But in the first, anybody know what she's feeling in the first one? Neutral, that's correct. Anybody see her as angry? I do. People who are more emotionally sensitive, in fact, the borderline sample, when they show this face, tend to see her as angry. There you go. So neutral, happy, sad, afraid, got her. So they show these 4 faces to people lying in an fMRI scanner, and they're interested in what happens to their amygdala. And here's what happened. With neutral, happy, sad, afraid, it turns out that for all 4 of the faces, the amygdala gets more lit up in comparison to healthy controls. So I think this fits our clinical experience, that patients with borderline feel things much more deeply than the average person. They see somebody's face, they've got more of a response to that. Their brains come that way. Now, darn, you got the double whammy. Oh, well, you can modify this. This was the additional study. They replicated this study last year, and they gave oxytocin. Oxytocin is the hormone released in large amounts around pregnancy and childbirth that helps mother-child bonding. It's sort of called the trust hormone. If you give oxytocin, all those findings go away, and the borderline sample looks just like healthy controls. That's kind of interesting. We don't have oxytocin available. It's only given intranasally. It lasts about 3 minutes. There's no real way to make that commercially available yet, but it's interesting. Now, the cortical response is also interesting. What you want is to be able to get people to think more in the face of that snake. What happens is people tend to stop thinking well and they move into action mode. They don't know what they're feeling, they're overwhelmed, and it quickly gets put into an impulsive behavior or a dysregulated emotion. All of the effective treatments focus on getting people to think straight in the face of difficult emotions. And that is really, I think, an important principle to work on. That it becomes an opportunity. Oh, and the patient doesn't want to go back to it. That tough thing I had yesterday, yeah, it's over, I don't need to talk about it. No, that's really important. What happened? Let's understand this. Getting in there and getting curious with the person about what happened can really do them a heck of a lot of good, no matter what type of treatment you're using. DBT gives you a structure for that. There's a chain analysis you do. Mentalization, everybody's got their own way of doing it. But the idea is getting people to think straight in the face of their distress is really where the action is. You're modifying the cortex. There aren't any current biological treatments to do that, although we at Mayo have been doing a study of transcranial magnetic stimulation, where we actually stimulate the right dorsolateral prefrontal cortex. And lo and behold, our data are like incredible. These are 2 depression measures. They both like dropped over 4 weeks and stayed down. It's interesting. It's not ready for prime time yet. We'll be doing more studies, but please don't send all your patients to Mayo for TMS. We're not doing that. But it is interesting to see that there may be some emerging biological treatments. Right now, there are very poor biological treatments. There are very good psychosocial treatments. All right. Hanging in, 3 of 5. Treatment. All right, so we're going to spend most of the day talking about treatment, and we've got experts at treatment. We're going to talk about different modalities, how you integrate trauma, how you understand things across a treatment. I'm giving the big picture overview. There are several now empirically validated treatments. They're all compared to treatment as usual. They all do far better. They have good data behind them. Dialectical behavioral therapy has by far the most studies and is by far the most accessible, but there are other good treatments. They run the spectrum. On the one extreme, cognitive behavioral, the other extreme, psychoanalytic or psychodynamic, but they have some things in common. They insist that patients think through difficult emotions. The treatment itself is coherent and stable, not reactive to the crisis of the day or the crisis of the week or what's going on. It's a stable treatment. Crises are expected. These are patients who have crises. Okay. Support and supervision is provided and required for treaters. You got to get each other's backs on this. It's tough. It's not easy for family members. It sure is not easy for the patients. And it's not easy for the treaters. All right, this is hard work. It pulls at you. You got to get some support. And you monitor progress. Is the patient getting better? Is this treatment helping? That's important. Way too many treatments feel good but are providing no improvement. Asking the patient, is this helping you? What's helping? Are you getting better? Staying on track with goals of care once you've gotten into a treatment is really important. If you want the 8-hour version of what I just told you, there's a course that John Gunderson and I run in Minneapolis this summer. If you'd like more on the principles across treatments that matter, called General Psychiatric Management or Good Psychiatric Management, and I think his book is out there. All right, so one more set of comments on treatment. And this one I get to tell you a story too. The next part I'm going to try to distinguish is the difference between having an emotion and reacting to an emotion. So the story starts, this is last fall World Series. I don't know if any of you are, well, I know you're probably not fans of the other team. So there's a good chance in this audience I may find some Red Sox fans, or at least temporary Red Sox fans. But I lived in, no, okay, sorry. You'll have to, this may be a difficult story to listen to if you really hate the Red Sox. But I lived in Boston for 6 years. It's a requirement if you live in Boston that you come to like the Red Sox. They put something in the water. I don't understand it, but I started liking the Red Sox. And so it's true. I mean, you really do. And you go to Fenway. It just do. So it's Game 5 of the World Series. Big Pappy, David Ortiz, hitting like 700. It was pretty amazing. All right, so I wanted to watch Game 5. My partner, Kevin, owns a restaurant, and for him to get off in the evening is no small task. You got to get coverage and all that, but we were going to have dinner together. So, and the concept I'm teaching, by the way, especially since this is being recorded, but even if it weren't, Alan Fruzetti taught me everything I know about this. if you ever meet Alan or you've ever come to one of his trainings, he's amazing. This is his work. But the story goes that it was game 5. We were going to have takeout. He owns a restaurant. He didn't really want to cook. Fair enough. So we're going to have takeout. And I'm not usually home from work by 6. We're going to get home by 6. We're going to have dinner, watch the pregame, watch the game. It was exciting. And I get home at 6, and there was nobody there. The dog was there. The dog needed to be taken out, so I took the dog out. And 6:15 comes, 6:30 comes. I had just gotten home from work early. I'm hungry, which is relevant. 6:45 comes, and Kevin strolls in about 6:50, maybe exactly 6:50. And I asked, where were you? In a way that may not have been a question. So what was I feeling at that moment? Anger. I was feeling angry. You guys are good. And so when I said, where were you, in a way that was not a question, what response did that elicit? Anger. Yeah, you're lucky I brought your dinner. You're lucky I brought your dinner. I mean, okay. So you got the story here. Now, what's the feeling that fits when you're looking forward to something that doesn't happen? Oh. Now, how do you get from disappointment to anger? Blame. Excellent. Judgment. You got to do something cognitively to get there. Now, at the time, I did not know I was feeling, I'm amplifying this for teaching purposes, by the way. My relationship's okay. But I was kind of pissed, so it's a good example. At the time, I did not know that disappointment was even in the mix. So let's diagram this out. You take an experience. I felt angry. I'm suggesting that anger here is a secondary emotion, has an associated action urge. I say that to the other person, it doesn't go so well. But if I can get at that primary emotion, that disappointment in this case, I might be going somewhere. Now, let's add a layer to this. What would be validating for my disappointment? What could Kevin say that would be validating? I'm sorry. Good. You guys are thank you. Felt very nice. I'm sorry, I love you. Yeah, that'd be great. Okay. And now if I say, where were you, in a way that's not a question, how likely am I to elicit, I'm sorry, I love you? No chance, right? So you got this situation where that if I express the disappointment, the primary emotion, to the other person, I elicit a validating response. So it's self-confirmatory. I understand what I was experiencing better. I feel better. We don't have to fume and watch the game. We can be like, oh, okay, yeah, I really care about you, and I was just looking forward to this because we don't get to spend much time together. All right, it's nice, and then we go enjoy. Or if I express the secondary emotion, I actually contribute to the invalidating response of, you're lucky I brought your dinner. So that you've got an important distinction here when you can try to identify when a person, any of us, borderline or not, can understand what's happening inside, express that directly, you're golden. It elicits the self-confirmatory experience, and you feel validated. If you're reacting, anger in this case, could have been shame, could have been other reactions, could have been behavioral urges. If you're showing your reactions, it's pretty darn hard to get a validating response. So it feels even more confusing and more amped up. Concept makes sense? Good. So from a medical perspective, people with borderline tend to seek treatment reactively. They don't get proactive health care. They go to the ER in a crisis. For migraine headaches, one of my favorite studies, they randomized 50 people with migraines to regular headache algorithm treatment. Like you get a preventive medicine, you get a medicine you take when you have the migraine, basic stuff. Or 50 patients So they randomized them to this treatment algorithm, 50 borderline patients and 50 non-borderline patients. And it turned out that the patients with borderline would have more medication overuse headaches, more unscheduled office visits, and they didn't respond well, so the authors even concluded borderline migraine is different than regular migraine. You've got people who are more reactive, seeking treatment more reactively. So the goal here is to help the person figure out what they're experiencing and what they're looking for. You can lower emotion and clarify experience by validating. Legitimize it. Get what's going on. Okay, that's what's going on. Got it. All right. Then consider what to do. Avoid but, use and. Both are true. I was angry and I was disappointed. Disappointment was the primary. Name the dilemma, but don't provide the solution. Let the other person do that. And try to be authentic. Try to be real yourself. It's a real relationship. You matter. Last section. I've got 5 slides left and a video. So briefly on medications. Those of you who prescribe medications, this is directed at you, but those of you who don't, this is important. The goal is, first of all, it's important to know there are no medications that are universally effective for this condition. There are a couple of signals, and I'll show you what they are, but there are no medicines that are universally effective. The goal is to collaborate, determine goals and expectations, and measure the effectiveness of the intervention. And for those of you who are psychiatrists, being methodical in the approach and saying, over the next 6 weeks, let's see if symptom X improves, is as useful as anything else. Because even if symptom X doesn't improve, you've done what we said is important. You've got the patient thinking about himself. How you do it matters. Polypharmacy is a problem. 40% of patients are on more than 3 meds, 20% on more than 4, 10% on more than 5. Oh my God, that's a lot of medicine for not much benefit. This is a summary of where there is some evidence. It turns out that the anticonvulsant mood stabilizers probably have some better evidence on some parts of this, but they also have more side effects. Women of childbearing age, not a simple process. There's other problems with this to manage. The antidepressants are much safer and not always as effective. The antipsychotics can help with some of the psychotic symptoms. I've left off a class. What's a commonly used class here? Benzos. Why did I leave those off? They're addictive, and they're the only drug, alprazolam specifically, that's shown to make patients worse. Why would that be? I think it has to do with people don't think, you need every neuron you got firing in moments of distress to think straight. And if you're giving something that works on the same receptors as alcohol, it doesn't tend to help enhance your ability to think through difficult problems. It makes you feel better, but it's not always a helpful idea. So I tend to really minimize that or use it just during acute crises. And then I've put this in your slide deck. I'm not going to go through all the details. But this is a chart that goes through when borderline exists with other disorders, which one would you consider primary and why? So that, as I told you with depression, you really need to consider borderline primary because the depression is going to get better if the borderline symptoms improve. Whereas early onset complex PTSD, some of our traditional borderline treatments don't do as well. And patients can be really vigilant and have difficulty attaching. And you got to think about what's going on with that. We're going to get into that a little more this afternoon.